So what are we going to do today?
Well, we're doing it. I wanted to kind of, I'll cut that last part out, but,
okay.
I want to just kind of pick your brain. I know obviously you've got your podcast out now. So I wanted to give you an opportunity to talk about that on this channel. And then also really, I just wanted to kind of pick your brain, and you brought up before neurotrophic and neuropathic pain. And that's one I don't think neuropathic pain is one I haven't completely been able to feel like I've grasped well enough. What's interesting is neurotrophic. I don't know why that is, but when new stuff comes available, it seems like you see things more. Like the amount of times I saw neurotrophic keratitis in the past that I recognize, pretty small. But now over the last 3 or 4 months, it's like, man, why am I seeing more of this? And maybe it's just because I can do more things about it, so I'm more aware of it. But what's your sense of that? And what's your sense of like neuropathic pain? And how do you manage that?
It's exactly the same. My diagnosed cases of neurotrophic keratitis prior to the introduction of oxygenate were 0 in my entire career, which has been a long time. And when I heard this was coming out, I thought, good for you. It's a rare disease. I'll never see it. And I think, a couple things to that, similar for blepharitis, now that we have Tarsus coming out with something, no doubt you're going to see more B88.0 for diagnosis codes because doctors are going to look. The ptosis with apneic, et cetera, now we have a way to treat that. So we look more, because in the past we couldn't do much about it. But the neurotrophic keratitis part is very, very interesting because, you get these patients coming back, you think maybe perhaps they have dry eye, they've got SPK, you treat them. They're not really complaining symptomatically, but you can't get the cornea looking good. And you simply take a little cotton swab and try to touch it, and voila, they can't feel it. And you think, oh my gosh, I've been missing it. And really interesting case. I had a 25-year-old woman who in her high school years wore nightwear Ortho-K, and she had this SPK. And I said, I'm going to test her corneal sensitivity. She said, oh, I don't have any sensation in my cornea. I can put drops in and I don't feel anything. Wow. And sure enough, we had treated her all the traditional dry therapies, and it turns out she was neurotrophic. Mild, but she was neurotrophic. And things like pars plana vitrectomy can cause neurotrophic keratitis, and even retina doctors weren't necessarily aware of that. So those innovations lead to education and awareness, and now we have a way to finally treat some of these patients.
Welcome to the Chris Wolf Podcast on iCode Media. Today I had a great conversation with Dr. Scott Schachter about his new podcast. It's called Ocular Surface Academy Podcast, and specifically it's dealing with digging into TFOS and all of the TFOS members and the different subcommittees within the DEWS 2 report to try to translate evidence-based medicine into bedside clinical care. It was a great conversation I had with Scott. I'd love for you to check out his podcast. You can find it on all the different podcast apps. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. I think we're in the best time to practice optometry. Yes, on this podcast, we've discussed the expansion of corporate entities, vertical integration, online retailers, and unproven technology. But I truly believe if we're taking care of our patients and offering the newest and best options for their eye health and vision, these disruptors will only serve as a clear distinguisher between what patients can get from them and what they expect from us. In our practice, we've had a ton of success for our patients in terms of comfort, vision, and stability with proven optical designs of CooperVision's Biofinity Toric. The Biofinity Toric multifocal combines that toric design and its rapid stabilization with the flexibility and customization of the Biofinity multifocal lens. This provides our presbyopic astigmatic patients with an excellent option for minimizing their dependence on glasses. Check out the show notes and link to CooperVision's website for contact lens parameters and more release information. Sorry, I want to get to the neuropathic pain as well, but the neurotrophic one is interesting because, it sort of opens up a Pandora's box, so to speak. It's like, well, is it HSK, or was it a prior HSK event? Was it, intraocular surgery? Do I need to be worried about some other form of stroke that may have happened in a patient? Like how far, so I guess my thought about Pandora's box is I can see clinicians wondering like, oh man, I look at Will's and it's all these other things. or can it be the case that we might just have a situation where you've got such chronic dry eye for so long that you become a little bit neurotropic?
Well, absolutely. All those things can cause that to occur. But when you have long-standing inflammation causing nociceptive damage, right? So the regular nociceptive pain that we get, those get frayed. And I believe, and I'm talking to Pedram Hamran and Ocular soon, and I'm trying to get a better understanding of how do you either go neuropathic, so you fire when you shouldn't be, or neurotropic, where you don't fire when you should be. So what's the differentiator and how does that happen? And can neuropathic actually become neurotropic? And I've got patients, so I can tell you, with very high symptoms, yet I can touch their cornea and they don't feel it. So those sensations could be coming from somewhere else, and maybe it's the conj, maybe it's the lids. So I think there's still so much to be learned about both of those disease states.
Last time we talked was almost, I don't know if it was close to 2 years ago when we talked on this podcast and about this specifically, and we were, maybe it was a year ago. I can't remember when. Well, no, maybe we were sitting down and talking at a meeting, but I made the comment about gabapentin, and then we were talking about neuropathic pain. And I still haven't wrapped my mind around how to differentiate between those patients who are, who are having neuropathic pain and how to best manage them. So what's been your sense of, like, okay, Chris, you see a patient with dry eye symptoms. This is how you, that isn't getting, that has no significant, or maybe you've fixed the significant ocular surface issues that you're seeing with all the other stuff, and we can talk about that. But now you're left with a patient who still has a speed score of 20 and no staining or minimal staining. And, or like, what is your thought process? And okay, this is what I do. These are the tests I do, and this is how I'm going to treat them.
Well, pain without stain, right? Like you're mentioning, and you maybe resolve, like you said, resolve the ocular surface and the pain persists. And the way I differentiate that's with proparacaine. Have you done that?
No.
So you got a pain patient.
But I know where you're going.
Yeah, but pain patient, right? So they're telling you my eyes really hurt. I can't stand it. It's driving me crazy. I asked them, okay, on a scale of 0 to 10, we're going to call this a 10. I'm going to put a drop of proparacaine in, and you tell me what happens. If that pain goes to 0, I know I'm dealing with peripheral neuropathic pain, right? And I also may have some potential to help that patient. So I might do autologous serum, amniotic membrane, cyclosporin have all been shown in research to help with that. So if we reduce the pain by numbing the surface of the eye, we can perhaps help them. If that pain stays at a 10, now we've got problems. I know it's all central, and that's going to be pain management referrals. First of all, it's going to be education. This pain is not coming from here, even though it feels like it's coming from there. And we need to manage that systemically. And some may tell you it's about 50-50. And well, that's about probably the kind of improvement we can get. We can work on the surface, but we may still require pain management. And I don't do a lot. I send that out, and there's a recent paper by Pedram Hamran and others about low dose naltrexone potentially helping patients with neuropathic pain. But a lot of it's just a lot of it's just very important to educate that patient. Their pain is real. And you may have been a doctor who are telling you there's nothing wrong with you, you're crazy. Well, it's like diabetic neuropathy. It's the same thing. You have pain, and it's just not related to the surface of the eye. It's the nerves that are just aberrant.
Who have you found to be the best people to work with in those terms? Like, are you working with anesthesiologists that specifically specialize in pain? Has it been even a more subspecialty group that'll take it seriously when you send a referral like that?
Yeah, if you can find a good primary care doctor who has a good understanding of that, sometimes some of these patients will already be under pain management. The other questions you might ask them when you're trying to differentiate, ask them about sleep, ask them about depression and anxiety, ask them if it feels like they have a paper cut on their eye, or when they see light or wind hits them, it's burning pain. Have you ever walked into an exam room with a patient who has a brimmed hat on because the overhead lights are driving him crazy? And I had a patient a couple of weeks ago referred to me. She can barely open her eyes. I mean, I'm trying to look. She can't. She sits in the room with her eyes closed. They're in that much pain. So all these things tend to go along with it: poor sleep, anxiety, depression, and you can even. I think there's some sort of a forearm test where you can poke somebody in the forearm and see how they respond to that. Patients who you put a drop in their eyes and it really wipes them out, really, they're hypersensitive to so many things.
Hmm. I get these patients too where you brought up anxiety, and it makes me wonder, because that's what I see a lot of, is that these patients that are, they finally get referred in to me and they've done, X, Y, and Z. And part of it is that the doctor that's sending them has tried stuff, but the patient is persistent, right there. And if you don't have a lot of experience, one of the detractors in terms of integrating ocular surface management in your practices, you get those patients where you're looking at them and it's like, oh, they should be feeling fine. Why are they so uncomfortable? Why are they calling me all the time? And every single little thing is bringing them back in. And it can be detracting. So like, you're like, I don't know, somebody else needs to take a look at this. And then you sort of lose your sense of confidence in the whole disease management process. And when you see enough of those patients, you realize that there is something with patients who have chronic ocular pain, that whether it's from dry eye or it's neuropathic, that will lead to anxiety. So my question really is the anxiety stemming from this fact that they are worried about being in pain so much, or does the anxiety actually cause the pain? What's your thought about that?
I mean, you could say the same about depression. I mean, it's chicken or egg. I don't think anyone really knows the answer to that question. If you have dry eye, you get depressed, or if you're depressed, you get dry eye. And I don't know that the answer to that is really known. And when you talk about making sure that, Dr. Carlos Belmonte from Spain, who's part of the TFOS DUES 2 pain and sensation, he was a subcommittee chair. We spoke a couple of weeks ago on the podcast, and he said, be careful not to jump to neuropathic pain. So be sure that you're actually optimizing the surface of the eye. And that comes into minor techniques like, when you instill fluorescein, make sure you're waiting a minute or two before you look. Ideally, if you have a Ratten filter, and I have this awesome Firefly slit lamp that I love, which shows pictures, and with a rattan filter, it brings up stuff so much better than cobalt blue. And I'm seeing a lot of these patients that actually have basement membrane dystrophies. In addition to this, corresponding, a lot of patients that I'm treating this way are also having anterior membrane or epithelial basement membrane dystrophy. So be sure that you're truly optimizing the surface of the eye rather than jumping to that diagnosis. But I think a lot of us have been overlooking it.
Yeah, I like the way you simplified the approach to, like, once you get to that point of fixing the surface, right, the pain without stain, or you kind of hit a brick wall where you're not getting any additional improvement, thinking through is it neuropathic, is it neurotrophic? And then if you think it's neuropathic, using I mean, it's very simple, right? Using proparacaine to go down that road. I've done that with other things before, but I haven't really thought about it in that sense. But I like your differential of, is it central or is it peripheral? That's really helpful for me. So then what are your, within the podcast, one of the things that I think are really interesting. So when Dr. Sullivan, when you were talking to him, that was illuminating. I don't really get into, like, when he was talking about, I think he went into like his CV for like 15 minutes, and I was like, man, just get to the, like, I know that I know that some of those guys think that, I'm sure, and he seems like a really nice guy. But what was really cool about the conversation for me was the history of like TFOS and DUES and DUES 2, and how different entities wanted to come in and control things. And like, that was really fascinating to me. And it, I've seen sort of a microcosm of it within stuff that I do, but it's got to be really challenging because you need industry to be able to kind of develop new things. It does open our eyes to those new things when we have ways that we can treat them. But what are your thoughts on that whole conversation and that whole area of DUES, and how were they able to really mitigate and manage those outside entities that were funding it from having too much drive in creating it?
Well, I think that's the doctors they chose to, the 150 ODs, MDs, PhDs who were subcommittee chairs, et cetera. I think they just chose a solid group of people who weren't going to be swayed. And as you know, maybe when you get into the upper echelons, people have their theories, and they're not likely to be for sale. So they're putting their reputation on all of this, and I think ultimately industry in general is fairly respectful of just, we're going to sponsor you and you're going to gather interest, and we don't. I mean, if it comes off as a bot consensus or a bot algorithm, I think doctors will see through that. And I've been, they'll make the treatment recommendation section is pretty broad. We talk about step 2 is to write a dry medication, and they're not going to tell you write 1, 2. There's 3 of them. They'll tell you write 1. Or in office meibomian gland expression, when there's 3 of those, I'm not going to tell you which one, but that's what you should be doing. And they really vetted the references. So I think when you put together a big team like that, to get all those doctors to agree on what's for lunch, let alone, hey, this sponsor wants you to say that, good luck. So, but they did put that. I mean, Dr. Sullivan's history, we could have spoken for hours on. I mean, he was doing research on dry eye probably before you were born. And I was
sure, yeah,
high school. Sure. I mean, in the 1980s, the things he was working on, these were really the pioneers, and they didn't sell out. And he was at Harvard for years at Scapins, and I get notifications by email when people cite his research, so I see what's going on, and I get 7 emails a day on his research being cited. I've met him before, but I never knew what a wealth of information he was. I have a new respect for all the work that he's done. That's the purpose. Well,
that's the cool part. Yeah, that's the cool part I was going to say about podcasts is that, we get to read about the literature that these people are putting out, right? We get to interpret it ourselves. And guys like you and me get to communicate that literature through our filter, right? Through our clinical and filter when we're communicating to ODs. But what you're doing is putting it right to the source. And how do they do the research? How do they interpret the what their findings are? And what is it, where are they missing? And so, what are your other thoughts about that?
Well, that's the genesis of this whole thing. I may have told you I met Dr. Essen Akpeck in Washington, D.C. when I was at a TPOS event. And she shared her story of how she was working with Sjogren's patients, and she could show if you had corneal staining, you read slow at 28 words per minute, I believe, over 30 minutes of sustained gaze. And that to me was just, oh my gosh. I mean, first of all, you can equate slit lamp findings to quality of life issues. And second, why have I never heard of you before? I bet you I've cited your research, but I didn't notice your name. And I thought, I want to put you people in the forefront. And after talking to Dr. Belmonte, he graciously sent me this really nice email, unsolicited, and said, I want to thank you as a basic scientist for putting our voice out there, because they're too busy, or they don't want to go out and talk about it. They're just too busy doing the work to go out and tell you what they're doing. So I wanted to highlight those people. There are a lot of us talking heads who go around and we reference all their stuff. But like you said, I wanted to go right to the people and learn what makes them tick. What was your inspiration to get into dry, and what excites you about what's coming next?
What has been you're planning a series of 20, right? A series of 20. And then I'm interested to see what you do with that afterwards, right? Because then there's this whole platform that gets built that, as I always say, is that one of the values of podcasts is the recurrence of it, right? You continue to explore new ideas and new topics. So I can't wait, way down the road when that happens. But how did you pick your 20? And so far to date, the ones that you have had, the conversations you've had, what's been is there been one thing that really sticks out in your mind of like, oh, wow, this was a light bulb that went off and now I got to change something else, besides the initial introduction into this idea as you just described?
Well, I came up with 20 really based on, there's, I believe, about 12 subcommittees, and some of them warranted more than one episode. So Dr. Belmonte, who was the subcommittee chair for pain and sensation, we interviewed him. Doctors Hamra and Galore are also part of that committee. They weren't subcommittee chairs, but they're part of it. But they're going to also have an episode on that, because I think pain and sensation is really something new. That's part of the new definition of dry. Talking to, Dan Nelson is someone who I never had heard of before. Had you heard of him before? Yeah, and
most of the guys that you've talked about, I haven't heard of.
Yeah, you'll
And
get
most of the,
your,
but in fairness, most of them are PhDs or ophthalmologists, right?
a lot of PhDs, yeah, and
Yeah.
MDs, both.
Yeah.
And straight PhDs. Fiona Stapleton in Australia spoke about epidemiology. Jennifer Craig and Kelly Nichols together, which was really great to see them. Then we had Dan Nelson, who's an MD PhD, with Jennifer Craig, who will be she's taking control of the next TFOTS workshop. So we came up with 20 episodes based on what I thought would be of interest to doctors. And the whole point is to take this massive body of work and try to make it digestible. So some of them were just going to be, I wanted to highlight more than one or two of the people behind the scenes because I think they offer a lot of value. I wanted to get some different perspectives.
So then my other follow-up question was there an aha moment that you've had so far with any of the conversations?
There's a lot of them. There were a lot of things. I was writing down a lot of notes. The fact that epithelial cells produce nerve growth factor. And so that was fascinating to me. So there's its own homeostasis of the corneal epithelium and the nerves. The epithelium feeds the nerves direct and feed the epithelium. And this homeostasis that occurred, this own little environment that occurred was really something I'd never thought of before or never heard of before, I should say. So I've learned a lot. I mean, I think that's been the biggest epiphany in not one moment, but oh my gosh, there's so much work that went into this, even just the definition of dry eye.
Oh yeah.
All the thoughts, because that led to future research. When you talk about prevalence of dry eye, it ranges between 5 and 50%. You know why that is? It's not because it's that much different. It's because of the definition of dry eye. So when they came up with this definition, there was just the minutia. Every single word was analyzed down to every single letter. So the amount of work that went into it was just overwhelming.
Yeah, I mean, it is it is overwhelming, and I think that's a detractor for a lot of docs. And I think you and I have talked about this before. Is that within Ocular Surface Academy and some of the stuff that you do outside of the podcast, but helping other doctors think about the ocular surfaces, it can be overwhelming to think through how do I do this in my practice. And yet, to your point, when you look at the prevalence of dry eye between 5 and 50%, and if you throw in meibomian gland dysfunction, you look at meibomian gland dysfunction and dry eye, you're talking about 70% of the population easy over the age of 40, probably. And yet, what an opportunity, right? Like, we could just be dry eye doctors, right? We could have practices full. Every single one of our practices, I believe this, could be full of is full of dry eye patients. We just are either embracing it or not embracing it. We could all do a better job of it, probably. But how do you translate all of that, all this complex detail that you and I really geek out about because we're already in the thick of it, versus how do you get a guy that thinks, yeah, I don't even know if my patients will want to do this. Like, how do you translate that into now you teach them how to be a Scott Schachter?
Well, you wouldn't want to be a Scott Schachter, but the whole idea of this podcast, this is designed to be
background.
This is designed to be translational medicine podcast. So we talk bench to bedside, and we want every episode we get from these doctors based on your findings. When Chris Wolf goes into clinic tomorrow, what should he be thinking about or doing different in his practice? So the idea is to distill it down, make it consumable, digestible, and something that you can put into place relatively simply. And that was really important. We can talk into the weeds about all this stuff, but it's meaningless if you're not going to use it in practice. So every episode, try to get out of them. Give me a couple things. And, I don't know if you probably know, I'm lucky enough to have Chris Starr, an ophthalmologist from New York, brilliant guy who put together the Ascaris pre-surgical preoperative algorithm. So he's very versed in that. Chris has had an amazing career. He's a great guy. So we get the ophthalmology perspective in addition to the optometric perspective, and that whole conversation, ophthalmologists can take away Chris's thoughts on that, and the MD, PhD, OD, whatever, who's a speaker. The idea is to make it translatable to the eye care world.
So the other point I was going to bring up about that is you, my sense so far has been you're the one that's kind of probing for a lot of those questions. I always, when he speaks up, I'm like, oh yeah, there's a co-host on that. Is that going to be the case for every episode, or does he take the lead in any of the episodes?
Well, Chris, I asked him to be essentially sort of a co-host. I mean, it's my entity, I should say. But I absolutely thought the MD perspective was critical, and especially considering that ophthalmology is a global profession and optometry is not, or optometrists are not in every country. And this was a very global effort. I forget how many countries took a role. It's in maybe the 30s or 40s of the researchers behind this. So, but it's funny you say that, because we've got Priya Gupta coming up, who's a good friend of Chris, who's going to be talking on management, or maybe on diagnostics. And I'd like him to kind of lead the way with that, since he knows Priya so well. And you get into the preoperative, the surgical stuff. I asked Chris, I want you to talk. You're a surgeon. I'm not a surgeon. I want to hear what your thoughts are. And so more and more, I'm trying to make this a joint effort, or get him more involved. He has so much.
Yeah, I mean, it's a great perspective from both of those standpoints to have, and certainly to your point, it helps you translate that medicine into other paths where they might just turn you off because it's just an OD doing it, right? "Quote unquote," just an OD. So it lets you permeate the science into all the avenues of eye care. So it's pretty awesome. One of the things we did discuss this a little bit on the last podcast, but it's always, every time I think about this, I think it is interesting to think about when you think about DEWS 2 and where they stage everything. What is in stage 2 always blows my mind, because I think most people think those things are stage 4 things, right? Like, if I have one takeaway from DEWS 2, besides the definition and including things like neurotrophic issues, or I guess they might not
neurosensory etiology.
That's right, and osmolarity, and the other one is, by and large, I think people are waiting way too long to use some of the medication and treatment, in office treatments, to approach their dry eye patients. Do you think that's getting better? And at what rate do you think it's getting better?
I do. I mean, I think especially on the ophthalmology side, recognizing that prior to surgery, especially with premium IOLs, that you really need to make sure those measurements are nailed down. Doctors need to more and more recognize that contact lens dropouts are often due to borderline dry eye patients. If you wait, you're not going to, I mean, it's important to our practices, right? Our contact lens side of our practice matters. And even now more than ever, I think during the pandemic, when you talk about Zoom education for kids, I'm for the first time in my career having 9, 10, 11-year-olds come in. They're asking their parents to bring them in because their eyes are bothering them. So this is a lifetime disease, and we should, step one is great. Artificial tears, lifestyle modifications, nutraceuticals, etc. But bring them back. And bring them back 3 or 4 weeks, and let's reassess. And if that's not right, well, that's when the experts tell you, it's not me telling you, it's not Chris Wills saying to do. That's when you write a script, or you go to my in-office expression, etc. So this stepwise approach, I think, makes it so simple, and it's going to vary. That's why it's called a practice, and that's why we get to make our own decisions. But you can look at the framework in terms of diagnosing and treating. It's all right there. And as a Vision Source member, dry eye protocol created, and lots of protocols being created. I visited a ton of practice, and they all have their sort of approach. But I'm always sort of saying, let's go evidence-based. Let's just start with the evidence. And that's where this body of work is that they put so much work into. So that's what I love about TFOS, is that they're really behind this worldwide education and putting together an expert consensus to guide doctors. And that's why, again, we're doing this podcast with Lyndon Jones is going to be part of management and therapy, and Sophie Dang out of Jules Stein at UCLA is going to be part of it as well. Or is that part of USC now? I can't recall. But we're going to get these ODs and MDs who are going to really help us understand how we should be approaching it in our practice.
Awesome, Scott. I'll be respectful of your time. I'm so grateful that you came on the podcast and talk about this project, which I have been enjoying so much so far. And tell us where everybody can find it. We'll put some links in the show notes. And
yeah, I mean, you can find it on ocularsurfaceacademy.com. And there are links to iTunes or Apple Podcasts. There's links to Spotify, and there's links to YouTube right there. The podcasts are embedded in the website as well.
Awesome. Scott, thanks so much for your time. I appreciate what you're doing, man. We'll hopefully see each other
I appreciate
in person.
You chance to get on your famous show, the world famous Chris Wolf. Imagine that featuring me. I appreciate it.